I'd like to welcome everyone to the Buncke Clinic Virtual Visiting Professor Series. Tonight, I have the distinct honor and pleasure to introduce a very dear friend of mine and one of my favorite people in the field of plastic surgery, my good friend, Dr. Alejandro Conejero from Santiago, Chile. Dr. Conejero is the Chief of Reconstructive Surgery at the Clínica Las Condes in Santiago. He is also the president of the newly formed Chilean Society for Reconstructive Microsurgery. Just by way of background, Alejandro obtained his MD from the University of Chile School of Medicine. He then completed his general surgery at the Massachusetts General Hospital in Boston, followed by plastic surgery at the University of Massachusetts. He was then an attending plastic surgeon at the University of Pennsylvania, as well as an attending plastic surgeon after that in New York City at the Montefiore Medical Center and Albert Einstein College of Medicine. He since then was recruited back to Santiago, and he is now the Chief of Reconstructive Surgery within the Department of Plastic Surgery at Clínica Las Condes at the University of Chile School of Medicine in Santiago, Chile. As I mentioned, he is the president of the newly formed Chilean Society for Reconstructive Microsurgery. He is his first president, and he will be discussing this as part of his talk today. He is also on the board of directors of the Latin American Microsurgery Society. I had the fortune of meeting Alejandro a number of years ago, actually in Chicago, at the ASPS meeting over a delicious slice of Chicago deep dish pizza. And we chatted for a while, and we had a lot in common, and so we stayed in touch. And a couple of years later, he emailed me and invited me very kindly to the American College of Surgeons Chilean chapter in 2017, which was being organized by him as well as our dear friend Patricio Andrades. And of course, I said yes. I'd never been to Chile, and obviously I wanted to see him as well. So this ended up being a fantastic trip. We spent a couple of days in Santiago, where Alejandro was an incredible host, and then we basically made our way from the city through the beautiful Chilean wine country to the coast. And this was a fantastic day trip. We're going through and tasting fantastic Chilean wine and food, and here we are at one of the many wineries we hit that day, and really an incredible place to go. So I think I encourage anyone who has the time after all this COVID stuff's over to make their way to Chile, because it's an incredible country. We then ended up in Viña del Mar, which is where the conference was, along the coast. Beautiful, beautiful place with, as you can see, beautiful sunsets. And this was a fantastic time to see existing friends and make many new friends. And I found out that Viña del Mar was actually a sister city of Sausalito, which is obviously one of the small towns outside of the city here. And I also found out that just adjacent, just south of Viña del Mar, the beautiful city of Valparaiso, is a sister city of San Francisco. So another thing that I learned on that trip, and obviously Alejandro was my guide and my host during that entire time, and it was incredible. Last year, so forward 2 years later, we then had another opportunity to meet at the Patagonia Microsurgery meeting. This was the first meeting of its kind, and for those who have been following the series, you've seen a few folks from this meeting who have given us fantastic talks. And this was another great meeting of flap dissections, lectures, and also some fun. And here is a picture of us doing some fishing in Patagonia. This meeting was organized and hosted by Jorge Urenda, as you can see here. And here's Alejandro on the right. And of course, any opportunity you get to spend time in the beautiful Chilean Patagonia, I think it's you'd be stupid not to take it. Alejandro, with that, thank you so much for being with us. It's really an honor and pleasure to have you. I wish this was in person, but obviously times are different now. And so we hope to host you in person soon in the future. But for now, I think it's really nice to have you virtually at least.
Thank you so much, Babak, for the invitation, and thank you for the introduction. It's a great honor for me to be here today giving this talk in such a special time for so many people, the whole world, and we as surgeons are trying to adapt to this new reality. When you invited me, I felt like, what should I talk about? I obviously have now some years of practice and some things that I can show, but I thought, maybe I want to give a message or say something to the younger plastic surgeons. And here we go. I thought about maybe talking about how to start a unit, a microsurgery unit in a place like Chile. I just want to make sure that you see my screen well.
Yep, we see it, and we can also see your pointer
Perfect.
during the talk. So if you want to point to stuff, we can see that.
So I come from Chile. I was born and raised in Chile. Some people, not sure if everybody knows where Chile is exactly, but it's right there. It's in the on the Pacific side of South America. It's a very long and narrow country. Santiago, the capital, is right in the middle, and about 18 million people live in Chile. This is a longer story, but how does a young physician from Chile ended up training in such great places in the United States? Well, that's another talk, but basically I had the chance to start my surgical training and complete my surgical training at Mass General, and I had the chance to interact with well-known surgeons in the history of American surgery, like Dr. Hermes Grillo, a well-known thoracic surgeon, Dr. John Buncke, who was one of the creators of Integra. At the time, the chief of surgery was Dr. Andy Warshaw, who used to be a well-known pancreatic surgeon. My plastic surgery training I did at the University of Massachusetts, and there was a big group, like a big family of plastic surgeons that were full-time faculty, but also we had guest faculty like Dr. Paul Manson, Mike Bentz, and a lot of opportunities for someone like me coming from a smaller country in Latin America. It was a great opportunity to learn, to train, and to apply certain concepts hands-on. The good thing about my training there was that it was heavily, there was a heavy training in microsurgery and hand surgery. It was a referral center for a big catchment area in different states. And we had the chance to perform a lot of micro cases as chief residents. So that was the day of my graduation. And I thought, with what I've learned and what I have received, I should try to do some innovation and maybe return to my home country, go back to my home country eventually, to try to do something different. Santiago is a big city. About 5 million people live in Santiago. Chile is a very centralized country. I had the chance to join a group, private practice group, but with a very strong affiliation with one of the medical schools in Santiago. At the time, there were 12 plastic surgeons practicing plastic surgery, and none of them was focusing on reconstructive surgery. So there was a big opportunity. There were, at the time in Chile, talking about 2008, only 3 plastic surgeons performing microsurgery, the 3 of them at other institutions, and mainly reconstruction, focusing on head and neck and lower extremity. There were also 2 head and neck surgeons performing head and neck reconstruction. There was a lot of interest from the residents, but there was clearly an opportunity. So that opportunity came to me in my second week as an attending with this case. I obviously started going to tumor boards and meeting with dermatologists and surgical oncologists and orthopedic surgeons. But this case was basically referred to me by the orthopedic surgeons in the operating room. They were about to do an amputation of this patient, an above-knee amputation. And they thought, maybe, you know, this new guy has something to offer, just so we don't amputate this guy's knee. This was a 45-year-old man who had a pretty bad truck accident and also had other injuries. So I teamed up with an orthopedic hand surgeon who had some experience with hand microsurgery, and we did a straightforward lat dorsi musculocutaneous flap for this guy, and he did quite well. He stayed in the hospital for about 10 days after the operation. We discharged him, and he eventually went back to Argentina. He was originally from Argentina. And this was a first for us as a group, as a division. And we also, a first in Chile. It was the first stump reconstruction, believe it or not. We ended up showing this case as a case report. We saw that a workhorse like the lat dorsi was a very good option for different reconstructions, and that amputation stumps could be reconstructed with a very good functional outcome. But the problem was, in my hospital, everybody had questions, like the OR chief. He would come up to me with like questions like, how many hours will it take? Are you planning on doing more of these cases? I mean, I've heard that some head and neck surgeon at this university hospital does these like micro cases and they take 20 hours, like that last commando recon. And then the OR manager would come up to me with, so how many nurses do you need? How many staff? I mean, this is going to take a whole day and you're going to take half of my staff. And also a plastic surgery chief. How many breast reductions can you do using the same OR time? So when you start out with a microsurgical practice, you have to deal with these things, especially if you're creating a new culture in a new place. But I had I was lucky because the orthopedic chief said to me, I have no questions, just go ahead, use my OR time. If you can help us with the soft tissue coverage, we can actually take care of sicker patients. And that was the start of my microsurgery practice. I performed many lower extremity reconstructions, mainly using straightforward muscle flaps, like the gracilis flap that I use for different types of defects. The gracilis, as you know, it's a very, I would say, versatile flap that you can use for soft tissue coverage and also as an innervated flap for other indications. We saw a lot of motor vehicle accidents, especially motorcycle, and with the new delivery, options that we all have. We tend to see more and more motorcycle driving in our cities. So a lot of big and smaller defects that we usually try to resolve and take care of with the gracilis muscle flap or different types of dissection of the lat dorsi flap. This was back in 2008, 2010. Also exposed hardware. It was very common to see wound dehiscence with exposed hardware. In this case, this was a 54-year-old woman who had a free fall from, she worked at a winery and had an accident, calcaneal fracture that was fixed, and then eventually had a full wound dehiscence. The natural evolution of open tip fractures at times is chronic osteo, and gracilis was a very good answer for these cases as well. This experience we published in 2013 in the Iberian, the Spanish plastic surgery journal, and that was our first paper as a group in microsurgery in the Spanish medical literature. But as any other group, we underwent through a process of evolution. We started to see complex cases, and this is something that usually happens when you have very good results with typical like flaps that everybody does. Then people start asking you, so can you do this more complex case, for example, like very extensive degloving injury with an open tibial fracture of the lower extremity, with a staged bony reconstruction that required obviously a more extensive flap for reconstruction. So in this case, and this was our first ALT flap for lower extremity reconstruction, we used an ALT as a fasciocutaneous flap with a very good result. The patient eventually underwent an arthrodesis and was able to walk again and eventually ride his motorcycle again. As we started to use the ALT flap, we saw more indications for more complex reconstructions. This is a case of a young man who was involved in a rollover MBA, had a complete radial artery avulsion with, as you can see, a very extensive soft tissue defect of the left upper extremity. The hand surgeons were planning on amputating this guy, but we thought that it was a very good indication for a flow-through ALT flap as described by Fu-Chan Wei. We dissected a very extensive portion of tissue, including 2 pieces of muscle from the thigh, and we're able to reconstruct, as you can see here, the proximal anastomosis of the radial artery and the flap vein to the comitantes, and the distal anastomosis of the radial to the descending circumflex artery as a flow-through free flap. The patient had a very good post-op course. We even used that skin island of the flap to harvest some skin to cover the rest of the defect. And from a functional standpoint, he was able to use his hand. It was a sensate hand, which made the whole difference, and had a pretty good result post-op. From 2008 up until 2013, that was the focus of our practice, of our microsurgical practice. We were doing lower extremity, upper extremity, some breast. We had to convince the breast surgeons that microsurgical reconstruction for the breast was a better option. And eventually we started to see the complicated breast reconstructive cases. And those were our first free trams and eventually free deeps as well. Then in 2013, a couple of our former residents who pursued training in microsurgery, both in Toronto and Miami, came back to our group. And then we were able to organize a replantation and micro-call schedule, which is really impossible if you're, a single surgeon type of practice. Even with 2 at times, it's difficult. But if you're starting a micro practice, you have to realize that you're going to be, at least for a couple of years, you will have to be available most of the time. And then as we organized the replant schedule, we started to get referrals, like this young 16-year-old girl who was water skiing and had a complete, like, degloving amputation type of injury of the right dominant hand. We performed a replantation that required a few revisions, washouts. Eventually, this patient went to heal completely. And as you can see in this short video, had a limited function, but was enough, and also had some sensation of the palm and thumb that also made the difference for her. You can see also in this video that she was able to, as a right dominant writer, was able to write again. And she's writing in Spanish here. I am writing with my right hand. She then sent us a video playing the guitar. So it made the world for her and for us too. We also saw some patients with indications for delayed, not so delayed, but in this case, it was a few days after the amputation, or delayed reconstruction with toe to hand transfers. In this patient, we did a first flap to reconstruct the thenar eminence, and after a few months, a second toe to hand transfer. Our experience in toe to hand hasn't been extensive. We've probably done a total of 7 or 8 cases in the last 12 years. After our experience with adult microsurgery, we started to look for pediatric cases, and most of these cases were found in the ICU. This was a 3-year-old boy who had an upper torso, very extensive and deep burn that eventually got infected. They admitted him to the ICU, progressed with a purpura fulminans, had his both feet amputated. This is a picture of his right leg, and you can see there a very extensive defect that was caused by an extravasation of an IV placed in the tibia. He had his feet amputated. So in order to try to stop a further amputation at a more proximal level, we had to plan on reconstructing that extensive pretibial defect, in this case with a lat dorsi. This flap, you can't really see here, but I could hold the whole flap in my palm. It was quite small. So we reconstructed the defect, eventually healed well, and he was able to do some rehabilitation long-term, eventually was able to walk again. Another case of purpura fulminans on a teenager, also a very sick patient who had drowned, and eventually, after resuscitating her, admitted to the ICU, progressed with purpura fulminans, same type of lesion. We did a very extensive debridement of both feet and reconstructed her with, in this case, innervated ALT flaps. You can see on the right hand, on the right side, there's a superficial sensory nerve to the ALT flap, and the perforator isolated before performing the deeper dissection. She also had a very good functional result, and also a sensate flap after a few months. Having a replantation schedule gives you the opportunity to treat patients like this little girl who was involved with her whole family in a high-speed MVA, had a very proximal amputation of the arm that we were able to, using vein grafts and local flaps, reconstruct. That was a very early picture after the replantation. So one of the things that we always see in pediatric microsurgery is a higher degree of vasospasm. Usually takes a longer period of time, especially when you're doing the case. And sometimes you think it's a technical problem, or you think that it's you know, a very early thrombosis of the anastomosis, but it's usually vasospasm. Blood vessels are usually bigger than you think, bigger at least than at times the digital vessels that we have to work with when we're doing finger replantation. But in kids, it's always good to try a replant, even if it's a borderline type of indication, because kids usually recover much better. In head and neck, we had the political problem, I would say, of the fact that there was an ENT microsurgeon performing most of his own reconstructions, but eventually he started to focus on the resections. And this is something that we see more and more often when young microsurgeons are trying to start a practice. They usually find the problem, no matter where they are, in the United States, in Africa, in Latin America. Usually when there are people performing microsurgery, it is a head and neck or an ENT surgeon that wants to do his own reconstructions. And that is something that we are seeing more and more, especially in academic medical centers. But eventually, in our case, this microsurgeon started focusing on resection. So that allowed us to start seeing patients and performing the reconstructions. We use scapula for mid-face reconstructions, with or without skin paddles. We used also fibula for maxillary defects. This was our first time doing a 3D model for preforming the flap before insetting it. And that was very helpful because it allowed us to inset the flap through the mouth without any other incision. In delayed reconstructions, this was a patient who had had a almost bilateral maxillectomy for cancer, sort of similar situation, using 3D reconstruction techniques, and also underwent a lower eyelid reconstruction with a forehead flap. Mandibular reconstructions, initially the cases that we saw were resections, cancer resections. But in this case, you see a picture of a woman who had severe osteoporosis, and after an MVA at a low speed, had a comminute fracture of the mandible that was reconstructed by maxillofacial surgery using a single recon plate that after a few weeks got exposed. This woman lived like this for many months before we were able to see her, and we performed a full mandible reconstruction using the total length of the fibula. With only 2 osteotomies and dental restoration, she was able to smile again. In orbital reconstruction, we're using more and more the ALT as a chimeric flap. It's a very versatile flap. You can dissect and elevate the flap in many different ways. This patient was a young man who was a biker, a competitive biker, and presented with an adenokystic carcinoma of the orbit that was initially resected and eventually had a recurrence that required a more extensive resection, as you can see, including a superficial parotoidectomy and orbital exenteration. We reconstructed this patient with a chimeric ALT flap, and eventually he healed up well and went back to biking, even competitively. It was a very good surprise for me to meet this patient at the New York airport one time. I was about to take a flight, and I see this guy who was calling my name out, and I turned around, and it was the patient who was visiting New York for work. Had some meetings in New York City. After our experience with head and neck reconstruction, we felt that it was time for us to start performing facial palsy reconstructions. This was our first innervated gracilis reanimation of the face. And as you can see here, this is the late result. He's moving the commissure and the right side of the face. This was a very good change for this patient, and the reconstruction was performed using the mesenteric motor nerve, which is a one operation, instead of doing it first with a cross nerve graft, as published by the Toronto group. In summary, ALT is a great option for mid-phase reconstruction. We use it very often. Again, it can be used as a chimeric flap, and depending on the defect, you can tailor the flap the way you want. After the years performing head and neck reconstruction, I can tell, and this is something that I know you know, but the young microsurgeons, you only need 2 or 3 free flaps. You need to master 2 or 3 free flaps for most head and neck reconstructions, and you can do it very well. It's usually better to use the neck vessels, and always think about the effects of radiotherapy, because there are times when you have to go back, even after radiotherapy. Some tumors have recurrences, and you can do another resection and reconstruction, but then you have to think about other options for recipient vessels and flaps as well. As part of our practice, we performed breast reconstruction, as I mentioned before. The first cases that we saw were, most of the women that we saw were patients that had other types of reconstruction with complications. This was my first DEEP, and it was also one of my board cases. But most of our patients had were delayed reconstructions. Some of them, as you can see, had some stigma of failed previous reconstructions with expanders and implants, and it was a very good option for us to start doing reconstructions with free flaps. Also in obese women, which is usually a very good indication for free flaps as well. In this patient, we performed a superficial inferior epigastric artery flap. And we're not doing that anymore. I think that it's at times a little bit unpredictable, especially in terms of fat necrosis and final contour. We also had a publication of our first few DEEPs in the local Chilean Journal of Surgery. In 2010, we had a very I would say, important experience as a country. There was a major earthquake that hit Chile, and due to that event, we saw some patients that had suffered some injuries. Some were not so severe, but also there were a few patients that had very severe injuries, as I will show you. Some buildings collapsed. There was also a tsunami. There were deaths and a lot of destruction due to the earthquake. Some low extremity injuries due to collapse of a concrete floor that we solved with an ALT flap. A smaller injury of the foot with some tendon transections, also solved with treated with a very small ALT flap with a good result. Probably the most severe case that we took care of at the time was the one of a 24-year-old who was involved in the collapse of a building. The patient had multiple different injuries. You can see here a very complex skull fracture with a epidural hematoma that required an acute neurosurgical intervention. But this kid also had a bilateral hand amputation, and we had to negotiate with the anesthesiologist and the neurosurgeon, and finally we were able to replant the dominant hand. We were not given time to perform both, and there was unfortunately not enough surgical or microsurgical human resource to do both hands at the same time. The patient also had a decompensation in the operating room while we were negotiating the return to the operating, the replantation of the second hand. And eventually the surgery had to be stopped and the patient had to be brought to the ICU. But he had a very good post-op course with a very long rehabilitation and a very adequate result of the replantation. One of the great things about our profession is teaching and helping younger generations of surgeons learn. I was part of the creation and then participated as a teacher in the microsurgery laboratory that has trained at this time, at this point, many generations of new microsurgeons in Chile with basic courses and more advanced microsurgery technique courses in Chile. In 2020, our hospital has grown. We now have a very qualified team of microsurgeons. There are 8 microsurgeons in our group, but I think that one of the things that I have clearly helped develop is a microsurgery culture in our hospital with a team approach. We have moved from performing mainly muscle-based free flaps to perforator flaps, although we do both, but nowadays we try to investigate and use different types of perforator flaps to solve different types of problems. We routinely use now CT angio and 3D recon for pre-op evaluation. A few years ago, we started using the venous coupler. That's a very good tool to reduce the OR time and help also convince the OR managers and the administrators that there are different tools that, although they're probably expensive, help us reduce the overall cost of our micro cases. We're using, especially in those flaps that we need to bury, like the gracilis innervated flap in the face, and that's a very good example. Or when we do intraoral reconstructions, we use a post-op Cook monitor with implantable Doppler. That is something that we also brought from my experience in the United States. There's a group, as I said before, of 8 microsurgeons, young, very active microsurgeons that are developing different lines of research and clinical practice and facial palsy, lymphedema, and gender surgery as well, gender and genital surgery. We have a very good team. You can see in this picture, there are basically 4 attendings and 2 residents. There's always a lot of interest, and that helps. It makes things more enjoyable, and also we shorten the operative time a lot. Microsurgical practice allows you to innovate, and every year there's something different. So there's a lot of evolution in the practice. We have moved from using muscle flaps to musculocutaneous flaps. Now we use chimeric flaps and perforator flaps for different types of defects. It's interesting because there's a lot of teamwork that involves plastic surgeons, residents, nurses, and also physical therapy, hand therapy, and other specialists as well. You're able to develop your own protocols based on evidence-based medicine for different indications for reconstructing defects, and at the same time, different protocols for monitoring your free flap postoperatively. There's a complexity of defects, but microsurgery gives you the diversity of options for reconstructing those defects. I had the chance to work as an attending in 2 very big and well-known academic medical centers in the United States. And that gave me the, I would say, question: how do we improve and extend the coverage of microsurgical care in Chile? And with the help of now 5 microsurgeons, we founded this new Chilean Society of Reconstructive Microsurgery in 2019. I'm currently the president of the society. And we also participate in the Latin American Association of Microsurgery as a society. And I'm very happy to be part of the board of directors of this society that this year, for the first time, started a formal interaction and relationship with the American Society of Reconstructive Microsurgery. Microsurgery not only gives you complex cases, it allows you to meet very interesting surgeons that share your own passion, the same passion that moves your practice every day. I'm here during a visit to the University of Chicago Plastic Surgery Division a few years ago. with my group of colleagues and my mentor, Joe Cerletti, at the University of Pennsylvania. I had the chance to work side by side with great surgeons like Joe, like Steve Kovac and Josh Fosnell. And also I had the chance to invite my friends like Bobak, and in this picture, you see Greg Evans from UC Irvine and his wife during a visit to a winery in Chile during a meeting that we had a few years ago. Here we are with Bobak during our fishing trip in Patagonia. We had a blast. It was really fun. And here I am with my mentor and professor, Dr. Ray Dunn, a former Godina Fellow and Chief of Plastic Surgery at the University of Massachusetts. I want to thank Bobak for the invitation, and I always end my talks with a big thank you to my wife and my family. Thank you so much for the opportunity, and I'll be happy to answer any question that you might have.
Alejandro, thank you so much for recapping your experience from first moving to Chile and doing the first free flap at the hospital, which I'm sure is something that's somewhat nerve-wracking, to developing a program where you have 8 microsurgeons and residents, and now it's kind of a daily phenomenon, if you will. So congratulations. I think it's a lot of work to get that done.
Thank you, Bobak. Thank you so much.
I wanted to ask you a few questions about
Yeah.
kind of the headwinds, if you will, with regards to setting up microsurgery in a place that has not had it before. I think obviously, you know, there are hospitals like ours where when I started, I just kind of came in and everything was set and everything was very efficient, and I had to do pretty much no work to set everything up. I just came right in. So one of them you mentioned in one of your slides was that you were getting some pushback from some of the surgeons and the OR director talking about the use of resources and so on. I would imagine one of the other issues would be the finances of purchasing a microscope, purchasing microsurgery instruments and sutures and so on. Was there a lot of resistance with regards to getting the equipment that you needed to do all these cases?
Well, I was lucky because it was a very good microscope when I started my practice. It was a brand new Leica microscope that the hospital had bought for the neurosurgery division, and some of these cases happen at various times, right? You start a case at times, replant case at 2 in the morning. So we didn't have at times a little bit of issue with using the neurosurgery microscope, but that was something that we had to fight for. And after people started to see the results of the cases that we were able to perform, if it was, you know, a minor neurosurgery case, they would change the schedule just so we could have that microscope in our operating room. I started doing microsurgery with my own instruments. I bought a couple of trays while I was in the United States, and again, it took a good 6 months for the hospital to say, okay, I guess you need these instruments, and we will see how we can buy you a new set. But every year it happened with purchasing the Cook probe, with the synovis couplers. Every time there's a new device that helps the microsurgeon shorten the operating OR time, you have to really show people that it makes an impact in the final cost of the operation. So that was something that we had to calculate. And I remembered we did that with the coupler. We had to show them that it was worth paying for the whole set, and not only the actual coupler, but you have to buy the whole set of instruments to be able to use the coupler. But that was one thing, the financial issue. And there's fortunately medical literature that you can show that it actually decreases the cost. Mm-hmm. But I guess the most difficult part was convincing people that you were doing, you were actually changing people's lives with these long operations. Some cases take 3 hours, but every now and then you have a big head and neck case where for some reason things don't go well during the operation, and it takes you a good 10 to 12 hours. So that is something that if it happens very often, people will start to complain that you're using a lot of resources for a case, but that is something that we all have to deal with.
Yeah, I think, we've had a number of talks in this series of people who are doing new things. Let's say, something new in, thoracic duct reconstruction, for example,
Yeah.
in kids, like Steve Kovac does at UPenn, or jejunal reconstruction or esophageal reconstruction with the jejunum in little children, like Amir Taginia talked about. And it all involved basically them getting the word out and discussing this with the surgeons who had this need. And it was an unsolved or unmet clinical kind of problem. And at the end of the day, I think a lot of what we do is we are surgeons. So we're there to basically help other surgeons, be it cover wounds or reconstruct defects after oncologic resections and so on. I think a lot of it requires a lot of communication and just kind of proving to the referral physicians that this is something that's needed. And I suspect what you had to do and what you did successfully was basically take cases, like you said, the difficult ones that always had problems and complications, and then show them that you actually had the skill set to solve this.
Yeah. We found that it was very hard for us to start doing deep flaps. Mainly because, and I'm sure this happens in other countries as well, a good portion of the breast surgeons at times, even for economic reasons, are performing their own breast reconstructions with tissue expanders and breast implants. And there's also the industry, is pushing them to do it. So for economic reasons, at times, it's hard for us to take care of breast reconstruction patients and show them that there are other options that are usually, from a functional standpoint, better in the long run. So that was how it happened to us. We started seeing the exposed, the infected tissue expander, the asymmetric result with a very unhappy patient, or the constricted breast implant that was painful and the patient couldn't just stand it and she wanted it to be removed. So the first cases are usually like that, not the easy, straightforward, like immediate reconstruction in the thin patient, because those patients will be usually convinced to go through the process of breast reconstruction with an implant.
Yeah, definitely. We have a Professor Bala from Chennai, India with us. Professor, as your webcam is on, did you have a comment or question for us?
Yes, a comment. I should congratulate Dr. Alejandro. I think the same problem every one of us have to start off with, especially in developing countries. Very important. Your talk is a very stimulating talk to the youngsters. And again, to have a lab is so important to start on the microsurgery, which you have correctly pointed out. I wish you all the best as a president. You can do a lot more to your country. Thank you, Alejandro. Nice talk and a very stimulating talk for the juniors. Excellent.
Thank you so much, Professor. Thank you.
Thank you, Professor Bala. It's always nice to have you on these talks. Alejandro, I had another question for you. First of all, congratulations on founding the brand new Chilean Society for Reconstructive Microsurgery, as well as your collaboration and association with ASRM and obviously with ALAM. I would imagine that's a big feat to get this accomplished. Can you tell us a little bit about if there were any challenges with that, or if there were any headwinds or resistance or things you had to navigate to be able to bring together like-minded people in a country where microsurgery may be relatively new, maybe the last couple of decades, in developing this?
Yeah. So the main obstacle that we had, believe it or not, was the Chilean Society of Plastic Surgery. They thought that creating this new society with a group of plastic surgeons that were all obviously members of the Chilean Society of Plastic Surgery would divide the family, so to speak. We're not a big country, and there are probably between 200 and 240 plastic surgeons for the whole country. So we had identified out of those 200 plastic surgeons, about 30 plastic surgeons that had done microsurgery or were currently doing microsurgery or in the process of finishing training. And adding all of those plastic surgeons, we were able to find 30 plus or minus. So we met with the plastic surgery, with the Society of Plastic Surgery board of directors, or the president, and we had to negotiate with them. And after 2 meetings, they found that it was a good decision that would help us not only organize the microsurgical care in the country, but also organize a training and be able to present ourselves, especially with the rest of the Latin American countries, as a separate organization that was focusing on microsurgery.
Yeah. Well, I think having the society is important for so many reasons, not just collaboration among like-minded colleagues, but I think also for trainees. I think the residents really need to be exposed to a professional society where the latest and greatest in microsurgery is being presented. And as we know, residents don't really have the resources to necessarily travel abroad to go to other international conferences. So I think that's one of the many reasons I think what you've done is so important in a country like Chile. So congratulations on that.
Thank you so much. Yeah, I mean, it's changed the way that most of the plastic surgery residents perceive micro now. They have more exposure. They can see, not everyone does everything, but in our group, we do certain things more than other groups, and they have the opportunity to spend time with all of us. So it's better for them. It's a broader training, and they have more exposure. In fact, now there's a very, like a marked interest in our residents every year. At least 1 or 2 of them try to go abroad for fellowship training. We've had people train in Australia, in Spain, in the United States. So it's been good.
That's great. I think that's one of the most important parts of this, is to keep the legacy going and get more and more people interested in this. So that's fantastic. Well, Alejandro, thank you so much for joining us. I know it's a little bit later over there. It's always good to see you. It's better to see you in person, obviously, but
yeah, definitely.
But this is the best we can do right now with COVID, unfortunately.
It's been an honor. Thank you so much for inviting me. I would love to see all of the people that are listening to us, their faces, maybe interact. I'm sure that we will have the chance to see each other at meetings. And if you see me, please approach me. Tell me that you saw the talk. One of the great things about medicine in general, but microsurgery in particular, is the good vibe and the good spirit of core that we have. I always love to go to attend the American Society of Reconstructive Microsurgery meeting. It's a fantastic group of people. I always learn a lot, and having this opportunity of presenting today, I think also allows me to interact, at least virtually, with people all over the world. So thank you so much for inviting me.
Yeah, and I think honestly, one of the reasons I really wanted you to give this talk was, there are always folks out there, because these are being recorded and they're being accessed on YouTube and on our website. There are many folks out there who are going to be in your position, where they're going to be at a hospital where there, is no microsurgery, and they're going to be the first person doing it, or maybe they're in an area or a country that doesn't really have a society dedicated to it. So I think seeing, how it's done and seeing that you've done it, I think just inspires, I think, folks who may be in the same position in their own country.
Yeah, I hope it does it. Thank you so much.
Thanks again. Please say hello to all of our Chilean friends, and I hope to be able to make it down there soon, hopefully.
I will.
All right.
Great.
Thank you so much.
Hi, Rudy, and the rest of the team. Thank you.
Will do. Thanks. Take care. Good night.
Take care. Good night. Good night, everybody.